Good day. Hello, this is Jess, and I am making some recordings today about endocrine problems. So I'll be breaking things up into chapters like I normally do. I'll be talking about pituitary problems, thyroid problems, and adrenals. One of the other major endocrine system things we have going on in our bodies is the pancreas, and that's the insulin system and other associated systems with the pancreas. And then the reproductive system is based a lot on hormones as well. We're just going to focus on these three organs for this week's learning. So endocrine problems, let's start with pituitary. And I'm going to share my screen so you can see what's going on. So pituitary problems, there are a couple things to know about the pituitary. The pituitary itself is divided into two parts: the anterior part that's towards the nose side, and the posterior, the side that's towards the back side, the bone side of the body. So the anterior pituitary gland excretes adrenocorticotropic hormone, ACTH, follicle stimulating hormone, not hair follicle stimulating hormone, ovaries follicle stimulating hormone. Although boys have FSH as well, just not as much. Luteinizing hormone, growth hormone, thyroid stimulating hormone are all sent out from that anterior pituitary. So things to know about this: some of the pituitary hormones use a direct communication, like they are not just the messenger, they are the message. So sending out that hormone directly impacts a process. If you send out growth hormone, the person grows. If you send out follicle stimulating hormone, the ovary is released from, or the egg is released from the ovary and it enters the fallopian tubes. Some of them are just the messenger and not the message. So they're middlemen. I figure that was an easier way to think about it. So what happens is the pituitary is just kind of like this. I'm going to sit up here and I'm just going to kind of monitor everything. And it's way in the middle. So we'll get there when we talk about interventions for pituitary as well. But like, if you were to like draw an imaginary line down the middle here between your eyes, and then you were to, it's just like right by like the temples, and draw another imaginary line like right through the temples, right back where like it feels really good to rub sometimes because you're like stressed. That's where the pituitary gland sits. If you remember the sphenoid bone from A&P, the only reason I remember the sphenoid bone is because I think it's so pretty. If you look at it from the side, it looks like a butterfly. But the sphenoid bone helps support the pituitary, keeps most of the brain where it's supposed to be, and then it has a little dip in there. And the little dip is where the pituitary gland sits. Fun fact. So the pituitary gland, when it comes with these middlemen, it'll send out a hormone, and then that hormone goes to the receiving gland, and then that gland responds with its own hormones. So like something's haywire, not quite right. So the messenger goes out and says, pituitary boss says you need to do something, and then perhaps adrenocortical or ACTH, the adrenocorticoid hormone, will be like, okay, let's do some renin-angiotensin loop stuff. Or the thyroid will be like, okay, let's do some thyroid hormone stuff. So there's two different roles for the hormones that come out of the pituitary gland. And so and then from now and for a little while, I'm just going to be talking about specific problems with specific hormones. So in acromegaly, you have too much growth hormone. So how people look with this is this is how it manifests. It has thickening and enlargement of bony and soft tissues in the face, the feet, and the head. People will end up a lot with acne, They will have leathery skin, and they will have a really deep voice because there's a hypertrophy, an enlargement of the vocal cords. So those of you who followed old classic wrestling, or you have watched The Princess Bride, probably recognize this gentleman here. He is Andre the Giant, and he's the third guy. He's a tall guy. Clearly, he had a lot of growth hormone compared to the other two. Pituitary gland, not enough coming out of the pituitary gland, and it's rare, but it's usually because there's a tumor in the way that's impeding that pituitary gland. So what will happen with this is there will be a problem with the end organs. So like, remember I said thyroid and the adrenals are impacted by those pituitary hormone messengers. So if there's not enough thyroid stimulating hormone coming out of the pituitary gland, there won't be enough thyroid hormone, and then you'll end up with hypothyroidism. So it's kind of a chain reaction. Again, so if you have not enough ACTH, you'll have adrenal insufficiency and kidney problems because those adrenals aren't getting the message that they need to be doing some stuff. And they rely on both the thyroid and the adrenals do rely on messengers from the pituitary to kick it up a notch if they need to. Remember when I was talking just a minute or two ago about the sphenoid bone and where the pituitary is actually located? Here is a cross section. So when a person has a problem with pituitary, we can actually take it out. And the way we take it out is, if anybody's ever heard the phrase up your nose with a rubber hose, this is what happened. We stick a rubber hose up their nose. And so what this is it's a speculum type device. It enters the air, it widens some stuff out. I'm going to grab a pen here. So this is all part of the deal. And then what will happen is the surgeon, pen, okay. All right, come on, pen. So the surgeon will then use this part of, I can't get the pen to work, I'm sorry. So the surgeon will use this very, very end part, the part that's in the pink red area. And you can see the pituitary gland just beyond the sphenoid bone, hanging out there in the sphenoid bone saddle. And then they'll break through this bone and grab the pituitary gland, and they can either take out the whole gland or they can take out tumors. So with this particular type of surgery, there's going to be some special pre and post-op care considerations that we're going to need to have. So post-operatively, what we will really need to do is make sure, there it goes. That's our little thing. Here's the pituitary gland right there. Sorry. So we will need to make sure that there isn't any that the patient isn't going to have any cerebral spinal fluid leak out, because we broke this barrier when we did surgery. We broke this bone right here to be able to get there, and so that leaves a potential for a leak, and that also leaves a potential for not only stuff to come out, but it leaves a potential for bacteria and germs to go in and create an infection in the brain. Infections in the brain are never good, never. So we want to be able to prevent that as best we can. And we're going to be observing the client for a CFSF leak, because if something's coming out, something could very easily be going back in, first of all, so risk for infection. Secondly, the brain needs the whole spinal column, the cerebral spinal fluid is at a certain pressure on purpose. So we need to keep the cerebral spinal fluid levels at a very tight window so that we can have the right pressure, because if we don't have enough pressure from the cerebral spinal fluid, we'll have brain problems, to be technical about it. So post-operative care gets to be pretty Lots of observing, because they'll have packing under their nose, like right here. And so what we'll be doing a lot is watching that packing, or like gently removing the packing and tilting it down just a little bit, seeing what color the drainage is, and then putting that back up. Because if we have halos of drainage, halos means that we need to send something down to the lab to make sure that we don't have cerebrospinal fluid on there. It used to be that we just would go with a halo and that's cerebrospinal fluid, and that's awful. But we need to do interventions, and then things need to get like escalated. Now most doctors are asking for confirmation in addition to seeing that halo on the dressing. So it's a pink halo is what it is. So you'll see like a dot and then like a halo of pink. Because cerebrospinal fluid in its essence is clear. It's got a lot of glucose in it though, so it's easy to spot when you're a lab professional. So there are posterior hormones too. So all of the ones that we just got talking about were the anterior pituitary hormones. Now let's talk about the posterior ones. Posterior pituitary hormones include is mostly just antidiuretic hormone. Let's just keep it simple, and we'll just do antidiuretic hormone. So ADH. So if you have too much ADH, you'll have syndrome of inappropriate antidiuretic hormone. What a revolutionary term, right? And then too little causes diabetes insipidus. This one's confusing. You're gonna have to like quiz yourselves and quiz each other on this one, because people this one's easy to get lost in. So antidiuretic hormone. No. Diuretic, urine hormone. So if you have too much antidiuretic hormone, no urine hormone, you will have syndrome of inappropriate antidiuretic hormone, SIADH. If you don't have enough coming out, you'll have diabetes insipidus. So what does that mean? SIADH is, here's a pathophysiology really fast. So you'll have too much antidiuretic hormone, too much no urine hormone. Then what happens is it actually shuts down water, or it increases rather the water reabsorption in the renal tubules. So those in the nephron, because you have the nephron bed and then you have renal tubules, and the renal tubules will have a chance to reabsorb water. They're just like grabbing all the water they can out of the renal tubules. And so what happens is then you'll have an increased intravascular fluid volume. So not in the blood. You'll have your blood way too thin because there's way too much fluid, because all the fluid's getting pulled out of the renal tubules. And then what you'll end up with is all of your lights will be off. Your fluids and electrolytes will be off. So you will have dilutional hyponatremia. So you have low sodium and decreased serum osmolality. The blood won't be thick enough. What does it look like when a person has SIADH? Here's what it looks like. So they will have low urine output. They won't be putting out very much at all because all of that water is getting pulled back in. They will have increased weight because all that water is getting pulled back in. And they will have electrolyte problems because they were retaining water, which thins out the blood. That increased weight, you can kind of tell. Low urine output, we can measure really easily, but these electrolyte problems will cause cardiac issues because all of the different cardiac muscles will be off. It can cause GI motility issues. It can cause cerebral issues. It can cause brain swelling. So your labs, when you do a blood draw and you look at a metabolic profile, you'll see low electrolyte values and low serum osmolality. That means they have diluted blood. If we do a urine sample, and we gather a urine sample, we'll have high specific gravity, which means there's lots of salt in there, and we'll have high urine osmolality, that means it's really thick. So it'll almost look like dehydration P, but we don't have dehydration blood. We have dehydration P and really diluted blood. So we're going to be looking for the underlying cause. Usually what the underlying cause for any sorts of people who have pituitary gland problems, this SIADH, it's usually some sort of head trauma or some sort of like, which is really bad because like if you don't have enough lights, then you end up with cerebral problems anyway. And so then we were always looking for SIADH when I was in intensive care, and we were always looking for diabetes insipidus because it really did tell us a lot about what was going on up here without needing to take a lot of extra imaging. So what we'll be doing is if it's just mild symptoms, we can just do a fluid restriction, like a 1500 ml or 2000 ml fluid restriction. We can also give them some furosemide or some loop diuretics. That opens up that renal tubule, and then the water will come out, and then the water will get passed into the urine, and we won't have the hyperconcentrated urine, and we won't have the hyperdiluted blood. However, these people really do need seizure and fall precautions. So this person is not self-transferring, if at all possible, because of the extra stress that the electrolyte imbalance will put on their brain. And in severe cases, instead of giving them 0.09% normal saline, which is like the standard saline that's everywhere, right? Excuse me, I have a thing. There we go. My foot was all jiggy. In severe cases where SIADH is really bad, we will do a thing called hypertonic saline. Hypertonic saline is 3% saline. So normal saline is 0.9. So this is over 3 times more concentrated salt in that IV. And this person's on the ICU. And that's to make sure that the brain has enough sodium to be able to run their neurotransmitters right. The diabetes insipidus. This is the second diabetes that I talked about. I said, remember, like 3 weeks ago when I was in term 2 orientation, I said there's 2 types of diabetes. There's diabetes mellitus, talked about that last week, and diabetes insipidus. This is diabetes insipidus. So there's not enough no-P hormone. Antidiuretic hormone, no-P hormone. There's not enough of that. So then the renal tubules aren't pulling that water back. They're just letting it go through. So that actually has decreased intervascular fluid volume, dehydration, internal dehydration. That internal dehydration, we will see increased serum osmolality. So we'll have a really thick blood. So that means we have really concentrated electrolytes, and legit, these people can pee out 4,000 or 5,000 mLs in 12 hours. It's a gross amount of pee, like in so many ways, so much pee. All right, so manifestations with this particular thing, or with diabetes insipidus, is polydipsia. They're really, really thirsty. Polyuria, they're peeing all the time. And they have electrolyte problems because of this dehydration, because the renal tubules aren't pulling any of that water back because they're getting lots of, or they're not getting enough no-P hormone. So you'll have cardiac problems, you'll have cerebral problems. And then again, when we pull labs, if we draw blood, we will find super concentrated blood with high serum osmolality. And if we make them pee in a cup, they will have low specific gravity and low urine osmolality. They'll have really dilated urine. So this 4,000 or 5,000 mLs that are coming out in like 12 hours or 16 hours, maybe 24, what will happen is it's like clear, like it looks like tap water. So care considerations, like I had said before, usually when you have either SIADH or diabetes insipidus, there's usually a brain trauma. Usually is due to some sort of accident, some sort of like, whether it's a closed head trauma or whether it's an open one, like they cracked their head open when they fell off of something, or maybe they were in a really bad car accident and they got whiplash and they develop what's called a coup counter coup. This is a high acuity item. You don't, coup counter coup is not going to be on your test, but they might have like a brain, like their brain got stuck around in their skull just a little bit. So what we're going to be doing is working to fix the cause of the brain injury, and the cause of the brain injury helps resolve the diabetes insipidus. We can also give medications to be able to stimulate antidiuretic hormone coming down the pike. We're going to be giving lots of fluid replacements. We could be getting some sodium restrictions, and we could be using some thiazide diuretics to be able to help this as well. So there's a few different interventions there. I'm going to stop sharing. So that was the end of pituitary problems. The next recording I'm going to make is on thyroid, I believe. So I'm going to stop recording.